This is a case of a pseudophakic patient, 15 years old, operated 9 years ago in Uzbekistan for traumatic cataract, and he is now resulted with a high myopia and also has got a yak capsulotomy done. He came to us for correction because he was developing amblyopia and a visual deprivation squint due to anisometropia. So we plan to do a piggyback SulcoFix IOL. His refraction, as you see, is -4.5 diopter sphere with -3.5 diopter cylinder. This lens is customized and made to the patient's size of wide to wide, and also toricity is preloaded in the lens, which means you just need to implant the lens at 0-180 and it takes care of the toricity of this eye. Now, this is a very interesting design of the lens. You will see some ears which I usually call the Mickey Mouse ears of the haptics. These haptics are very soft and subtle, and once they go inside the sulcus, they totally resist rotation. The diameter of the lens is measured in a diametrical longitudinal manner and is based on the wide to wide measured. So you need to give the company the wide to wide measure, the anterior chamber depth, the refraction and acceptance of the patient along with the pupil size. This is loaded in a simple butterfly cartridge, but you need to be very careful before you close both the flanges of the butterfly cartridge, because the haptic size sometimes can be extending into the locking area and can end up breaking the haptics. So ensure that the haptics are well within the tomal chamber of the cartridge. Lock the cartridge and then visualize it that none of the haptics is caught in the channel. Now you will see this eye has already been pre-marked with 0-180 degrees. So these are Smart Toric lenses where you just need to implant the lens at 0-180 without any rotation. You need to be very careful because rotating these lenses sometimes can be tricky. And also, if you don't get the sizing right, implanting the lens into the sulcus with long haptic ears is tricky. So I instill viscoelastic in the anterior chamber, then slightly lift the iris by injecting viscoelastic under the iris. You will notice that a yak capsulotomy has already been done in this patient. So you have to be very careful. We have to avoid pushing the lens downwards, so that might have a vitreous leak. The lens opens very gradually in the anterior chamber. I prefer always opening the lens onto the iris rather than pushing it behind the iris into the pupil. Once I align the lens to the relative axis of implantation, that is the point where I start enclavating or inserting the haptics behind the iris and into the pupil. It's a good idea to ensure a complete dilatation of this particular lens. So we will fold the haptic. These are very soft haptics, but once they go inside the sulcus area, they will hold on very well. We fold the haptics by pulling the lens down and then pulling the lens downwards, folding the haptic, release it behind the iris. Now you will notice that the toricity mark has now been aligned. The same process and step is now repeated for the opposite side. The lens haptic, being very soft, goes inside the sulcus very easily, and now you will see that the whole dilated pupil is now covered, covering the complete optic size of the lens. Toricity is now reascertained, confirmed that the 0-180 degree is aligned. Now that's the best part of this particular lens, that you do not need to dial this lens. Toricity is pre-built into this lens. This patient had a toric angle at 105 degrees, but we did not need to place the lens at 105 degrees. We just needed to place it at 0-180, and you will see as the viscoelastic is now coming out, you are seeing a beautifully well-centered IOL and a round pupil. The effect of the lens is immediate, and the patient starts seeing improved vision within a couple of minutes of the procedure. The lens is well centered. I hydrate the wound, and the best part about the lens is that it resists rotation due to a unique haptic design of the IOL. So this patient was taken up for a piggyback lens for a simple reason, that he had a thinner corneal profile. Number one, he was a person of growing age, and he was a patient who wanted to be having a choice of getting a LASIK done at a later stage, once explained that the power may increase as he grows older. So we did keep the reserved corneal tissue because the initial cornea itself was on a thinner plane, and we implanted a piggyback lens in this patient who did very well. Thank you.